Good morning, everyone. I'm Corby Kummer, Atlantic editor and editor of the Aspen Idea magazine, which I hope you'll read cover to cover. And I have the pleasure of talking this morning with Dr. Eric Topol, who is a cardiologist at Scripps, genomics professor at Scripps Research Institute, chief academic officer for Scripps Health, director of the Scripps Translational Science Institute since 2006. Are you at Scripps?
All things Scripps.
He had been at the Cleveland Clinic, where he made it the #1 heart care center, and he's author of numerous books and named one of the rock stars of science by GQ. I think he can also say he's been named one of the rock stars of science by the Aspen Institute, because we can't resist having you back anytime we possibly can. Well, we're going to be talking today about wearable devices, which everyone's really interested in, and owning your own data. But the larger topics are going to be taking control of your interactions on your own health with your doctors, which is certainly a topic, I think, of interest to all of us, especially us here at Aspen. So since the last time we talked, when you did some show and tell, and I'm very excited to say, yes, there will be show and tell today. You did come to the right session. You're going to get to see some little tiny devices in action. But what are some of the devices and advances that have excited you since we last spoke here at Aspen?
Well, I think it's blossomed a lot, Corby. That is, we started out, of course, this whole field with the activity tracking, which was not medical, it was really health, lifestyle. Moved into all these medical metrics via sensors, the wearables, but now smartphone labs and doing the physical exam, and then Ubering a doctor through your phone to either come to your house or have a telemedicine consult.
Is there going to be a new app instead of Uber, to force a doctor to come to your house on demand?
Absolutely.
That really would be useful. And do you mean an Uber-like app, or do you mean an extension of Uber?
Well, one of the 5 that are currently operational, there's 5 of them. One of them was co-founded by an Uber founder, and the doctor comes on an Uber car, actually. But the 5 that come to your house, one of them is called Heal. It's backed by Lionel Richie. And when you say, when Lionel Richie's getting into this stuff, it's kind of makes a statement. And I had recommended to Lionel that he ought to change the name to All Night Long. He wrote back and said, no, it's all day long, too. But the fact is that
That's what I was about to say. I didn't know I had anything in common with Lionel Richie.
I didn't. The doctors are going to the patients now. That's a different look. You know, house calls in the 21st century.
Are they going voluntarily? This isn't just some dream of the future. We're going to compel doctors to make house calls?
No. This is a sign of the times about this whole bottoms-up medicine, where patients, this truly is the democratization. Patients are going to have much more power and say. That's just one dimension of the change here.
And in fact, I'd like you to continue on the cell phone app theme, because we have devices here. We talked about devices last time you were here, but we didn't talk about so much that one could do on the cell phone we all have in our hands and pockets.
Yeah, we can go run through I only have a sampling of a few that are kind of tell the story. One that has been around for a while but just keeps getting better is being able to do your cardiogram through your smartphone. You want to do yours?
Yeah,
No?
I never want you to do mine. Okay, I'll do it as long as you don't tell me the reading. I don't even want to know my data, let alone own my data.
Tell you what, we just show it to them and you won't even have to look at it.
That's just fine.
Okay. So you just pull up this app, put your thumbs or on either one of those sensors, right? And pull up the app. And
by the way, I shouldn't even ask this. I'm an Android person. I admit I don't own an iPhone. Does that mean that I am shut out of all these advances?
No, actually, they all work on Androids or Droid phones as well.
Ah, okay.
Yeah.
So just because I'm relentlessly uncool.
No, you're fine. And your cardiogram looks good, too.
See, as a cardiologist, I feel so relieved already. And if you come up, you can be relieved, too. Eric has all day to take your cardiogram.
But that's just the beginning.
In fact, I remember when we did this once, it wasn't so seamless, and I think there had to be a connection, and it was an extension of the phone. So it does actually look different, and I wonder, what's the kind of evolution rate of these devices?
Well, the difference now is not only you get the cardiogram, but you get the software interpretation. So it'll tell you whether it's normal or what abnormal rhythm you have. and that could save a trip to the emergency room. It makes a PDF immediately, so you can send it to your doctor and get the interpretation.
But we get into immediately one of the core questions I've wanted to talk to you about, which is, you said it prints out an interpretation. Whereas if I were a doctor, I would think, I like the idea of easy access to information. That I really want that PDF. I hope there's some kind of degree of reliability of the data from this new app. That's great. I don't want them knowing what it means. That's my job. And they're going to be panicked and they're going to ask me to do things I don't wish to do. So who does the interpretation? What do you think about that whole idea?
Well, for cardiograms, for 30 years, it's been interpreted by computer in hospitals. But
that wasn't something doctors told you. Well, the computer told me. They just said it was my infinite wisdom, right?
All right. But as it turns out, we don't want to diminish what consumers, patients can handle. They actually can handle this information extremely well. I mean, I have lots of patients who have heart rhythm issues, and they have this app. It's a consumer or FDA approved one, and it's really made their lives a lot easier and simpler. And they've saved a lot of visits to things like emergency rooms and urgent care clinics.
When you say FDA approved, do you mean the reliability, that this is practically as good as going in and losing an enormous amount of time to get your EKG done? But did FDA have anything to do with approving the interpretation of it? Is that something that's just outside their purview?
No, they had to go over the algorithm to make sure that when it makes the diagnosis of atrial fibrillation, it's accurate. And it's as accurate as the system that's been used for decades in hospitals. So that had to be done in order to have that software embedded into the app.
So this is one of a series of interpretations of data that we can suddenly get that I wonder why doctors don't worry that patients are going to start panicking in some unacceptable, needless way, or worse, treating themselves in a counterproductive way.
Well, I mean, I think the cardiogram is a special one because an average person without medical, in fact, a lot of doctors can't read cardiograms, no less the public. So that one is I think, somewhat of a unique story in that you need a cardiologist or somebody with real training. But let's go to something that's a little more a diabetic wanting to see their glucose. Okay?
Good.
And so there people understand what glucose is, and so you can just look on your phone. And by the way, first you have
Where's the hardware component of that?
I'm glad you asked.
I don't think you just have a pad.
So this is the hardware component. It's a sensor. And there's different versions of this. This can have micro needles that you don't even feel on your skin, on your arm or your abdomen. Or there's one with a hair-like needle. It's very thin, and that goes under the skin. It hurts, but not nearly as much as a finger stick. So this has to be worn, and then your glucoses go right to your phone like this, okay?
You know, I just have to say, how many here have seen finger sticks for diabetic friends or patients? They're fairly common. We've just seen them. And so it didn't occur to me that there was an alternative to an actual needle. When did that come about?
Well, finger sticks are going to be out over the next few years because, they're relatively expensive. They could be almost $1 each time you do it. A lot of diabetics have to do this multiple times a day.
Sure, of course.
And so not that's the expense, but it's not like you can do this in public. It's not a very social thing, and it hurts. It hurts. And so this is the way to get a sensor that's going to be very inexpensive, which will go on for a week or 2 weeks, and you can shower and exercise and everything else. And it's factory calibrated, so you don't have to bother with these finger sticks. So that's really a big, and not only that, but finger sticks are probably, in general, going to be an old story because these microneedles can bring up a droplet of blood without any pain. So that's another big advance separate of diabetes. That's just for all kinds of lab testing.
You said it can factor in your calories? What can it factor in, sorry?
No.
Well, your glucose can factor in because I wondered if it meant caloric intake, which would really improve
we don't
diets.
have a sensor that gets that yet.
Okay.
Maybe someday. There's been some attempts at it, but I don't believe any of them are very accurate.
And would this glucose monitor be connected to some sort of central server that a doctor could access? What happens to that information?
Well, the doctors don't really like looking at all this data. That's the last thing they want to be dealing with is a flood of data. So they want to just get the skinny, the summary, like a one screenshot kind of what's going on with the patient. And it's going to be the patient's call as to whether they want to send that and when they want to send that and who. So that's, again, another reflection of this change of power. But basically, the software here for glucose, and by the way, this also goes to the watch, so you can just look down at your watch and you can see your glucose at any moment in time.
Okay, I just had an alluring view of that watch. What watch is it?
That's an Apple Watch.
Okay, how many here are wearing an Apple Watch?
So, yeah, I'm sure. So.
Oh, yeah, I thought it was going to be very few of you, and I'm so glad that you're wearing one.
Well,
They probably sent you one in the
no, they
prototype
didn't.
phase.
Not Apple. Are you kidding? Oh my gosh, no. But here's my glucose on my watch, 86 right there. And you can also look at your trends. And by the way, if my glucose by preset goes too low or too high, I'll get an
alarm?
A haptic hit on my wrist to tell me my glucose is out of whack.
Where is the small patch? Where are you wearing it? If you can reveal this information.
On my abdomen.
So is it something that you put on every morning?
No, you wear it for a week or 2 weeks. Usually 10 days is about average.
And is this something that people who have not been told by their doctors you have reason to be concerned about your glucose level should wear, in your view?
Well, let's put it this way. There's 1 billion people on the planet.
I'm really asking, why are you wearing this?
Well, I'm not diabetic, but I'm trying to understand for diabetics, does this system work well? Is it really useful and practical? And I actually think that now that it's even on the watch, it becomes, probably today, it's the biggest advance for a smartwatch for medicine, being able to have glucose glances. You don't even have to take out your phone and you can just look down at any time.
Is that a trademark name, glucose glances?
I actually should trademark it, yes. But no, it's glances are the thing on the watch when you can look at a lot of information like this. And I just turned into glucose glances, that's all. So.
And what other applications? Yeah, nobody go out and trademark it, please, until the end of the day, till close of business. What are some of the other Apple Watch usages that some of these devices go to? Because that's, I think, something we all. You brought in cell phone, which is fascinating because it's so much more accessible to us. But I thought somehow that there was going to be a lot of concentration on the wearable watch and wearable devices.
Well, I'll go to another watch in a second, but the only other medical thing that I'm impressed with on the Apple Watch, it does do heart rate quite accurately, and that's nice, but that's not that medical, it's just heart rate, not rhythm or anything. But the thing that I'm impressed with is the medication adherence and reminders. So there's an app that you can use, actually comes through WebMD, and you can put your medication times that you take. And so it will remind you, you get that same notification on your wrist that something's going on, and you look down and you should have to take your medicine. And it also says, did you take it or skip it? And so then it dings you if you didn't take it. So you could lie and say you took it and you didn't, but that's probably not a good idea. So it tracks your adherence. And as you know, Corby, adherence is a big problem in medicine. About 50% of prescriptions are not followed by patients, irrespective of their education and socioeconomic background.
Yeah, I was at a conversation about doctor satisfaction among numerous other subjects yesterday with the American Medical Association, and adherence to regimes is an enormous problem. But is there the thought that people somehow, it will actually work to be nagged by these devices as opposed to DOT directly as their observed treatment? That it's a useful reminder because it's huge, and I gather that people who don't like the color of their pills decide they're just not going to adhere to regimes.
Yeah, I mean, I think there's lots of different ways that this adherence now can be tracked. It is a big issue, but actually an even bigger one is that the medications don't work in people. 80% of medicines that are given today, of the leading drugs that are prescribed, don't work in those individuals. Talk about waste. So if you're not adhering to a medicine that doesn't work, it's like, so what, right?
So that gets us into how to take more control of your own health information. And do you want to talk something about that and the way that these devices, which are fascinating in their individual application, can more broadly be used to change the relationship between patient and doctor?
Well, it's about having the information about each individual. So in the case going back to drugs, every person who gets prescriptions should have pharmacogenomics of that drug if that information is known. And for over 120 drugs, we have there's an FDA genomic label which says if you have this particular genotype, you shouldn't take this drug or take this dose or watch out for this serious side effect. And we don't use that information in medical practice today.
Is that not because it's much too expensive and complicated to gather?
Well, it isn't actually. In fact, when 23andMe was up, you could get 30 of these drugs output for $99 and a whole lot of other stuff. So there are ways to make this very affordable, but the medical community has not embraced genomics for drug use. And it's really a problem because every week there's new drugs that we have genomic signatures about who responds and what side effect can be avoided, and we don't use this information in practice. So that's another thing that each individual should be in tune with, that when they get a new prescription, think about whether or not it's going to be right for them, that they're going to respond to the medicine.
But how in the world can they think about it? Is there an app they can go out and buy? Can they say to their doctor, I know you're too lazy and overworked to find out about this, but I want to know if this will interact with my own genomics well?
Well, I mean, for medicines that are new prescription, you could, let's say statins, one of the most commonly used drugs. You could put statin and genomics or genetics, and you would get some information about if you have this particular gene variant, you're going to get very severe muscle inflammation, and you probably shouldn't take this medicine. And so then you would say, well, why didn't I get screened for this? So I don't have to feel like I had the flu and can't get out of bed for a week. So, you know, there's ways that we could start to get patients, consumers armed for information. This is just one example.
And that implies a level of information that I think very few patients have or know to have. And should it be on a warning label? Do you think that this should be part of the doctor's conversation when she or he prescribes a statin, for example?
Well, actually, I think that you should have in your mobile phone all your genetic interactions. It should be there, so that if you ever do get prescribed that drug, then you know in advance, and you don't have, this could be done in pharmacies when you get the prescription filled. I mean, it takes 10 or 15 minutes to do a genotype for a drug.
Can you tell us how?
You take a little saliva, and you do a test on the saliva for the genotype of interest. It isn't available yet. There was, at one point, a lot of interest to do this, but it was squashed by the FDA and the AMA. They weren't too enthusiastic about patients getting their genomic data from pharmacists and not from doctors.
So we're not going to be seeing it in minute clinics soon?
Not soon, but eventually we'll be there. And eventually, of course, people will have a lot more than just their drug DNA interactions in the future.
But is it coming, do you think, as part of a routine physical, that this is a kind of test that a doctor will order?
Well, speaking of that, the routine physical, which, by the way, has been around since the 1920s, has no validation that it helps. In fact, if anything, it might do harm because so many doctors order unnecessary tests with that annual physical. But what we're looking at is a whole different...
How do they make their money? I mean, of course they have to do this.
But we're talking about a different look. So we're getting back to this one drop of blood. You can now, for $25, get the entire virome history, every virus you've been exposed to through your life, and when. You can get with a drop of blood, in fact, just this week, you can make the diagnosis of Ebola, that you're infected, or you can find out about cancer risk, that you have the earliest sign of cancer. And so this whole new idea of a molecular stethoscope, and it wouldn't be at all unanticipated that in the next few years you would get a blood sample on an annual basis, or perhaps more frequently, to assess all these things through a very tiny amount of blood, this molecular stethoscope.
But there's still this enormous barrier, I think. It's when you say you can get this, I think a lot of people in this room would be mighty curious about whether they have any of this exposure, and they'd like to get it. But I don't think it's such an easy step-by-step process to call up your doctor's office and say, you know, I'd like this. Can I schedule, you know, my blood to be drawn for this?
Right, so that's why we are at a very different time in medicine. That's why this is kind of this Gutenberg moment in medicine. And that is because back in the 1400s, when there was the printing press, that democratized information. This is amount of doing that for medical information. We've never had that before, but all the things that are coming together now are actually enabling that to occur. That is, this information, whereas before you would do a Google search in the 90s since it was an internet and search capabilities, and it was about other people. Now you're generating your own data, and you're going to be generating immense amount of data. So for example, blood pressure, instead of the way blood pressure has been done, one-off visits to a doctor, like your annual physical, you can just wear a watch and get your blood pressure with every heartbeat. And that can be while you're sleeping and when you're in stress. And you don't have to press start. And you're getting blood pressure that was previously unobtainable, and a lot of it, real-time streaming in your real world. So this is amounting to terabytes of data for potentially millions of Americans who have high blood pressure, the majority of whom is poorly controlled.
But are they not terrifying terabytes to a healthcare provider? Speaking of seas of information people would drown in?
No, that's why we have these things called computers, and that's what they're really good at. And that's what machines can do, is interpret this data, process it, and in fact, not only get it all summarized, that's the basal thing, but to actually get into predictive analytics and deep learning about you and what brings your blood pressure up, for example, or your glucose, and how you can, giving you text or voice coaching about how to get better control of the chronic condition that you're trying to get your arms around.
This idea of individual control and taking more responsibility and control of your information, in fact, in the future, do you envision that most people would wake up and see whether their blood pressure had been abnormal and do something themselves about it? How much will healthcare providers be involved in intervening?
Right, so Corby, that's the biggest change of all. That's the thing that is so transformative, because the doctor-patient relationship was about doctors' orders and doctors having the control, autonomy. And now what we're talking about is a co-pilot, this type of partnership relationship, where the patient is armed with their data that they don't own yet, but they need to own.
What do you mean they don't own yet?
Well, in 49 out of 50 states in the US, the doctor or hospital owns your data. Unless you're in New Hampshire, your data.
Live free or die. You know that's on the New Hampshire. That's on the New Hampshire license plate.
Right.
I'm from Massachusetts. We see them every day.
Yeah. So while we're celebrating all the great advances, in our kind of recent libertarian world, which is great, we haven't yet done one that's really critical, which is giving people their data that they should rightfully own. But that will happen eventually, because you're going to be generating more data than what's in the traditional hallowed medical records, which are, of course, dispersed throughout many different providers and health systems in the Tower of Babel. So you have this idea of the patient is armed with data, and the new look is you go to see the doctor because you've got this data, and you've been given some counsel that you should go see your doctor. And you say, would you like to see my data? Would you like me to share it with you? That's a whole different kind of look than what we have today.
So you envision, I think, a future in which people not only have access to their electronic health records, their EHRs, you've all got to memorize that now, I want my EHR, please, but that they are willy-nilly downloading apps that they have this feeling, they wake up thinking I might need this, and then they present that doctor, that overworked doctor, a whole array of data. Or, how will it work?
Yeah, well, the overworked doctor now has gotten a whole lot simpler life, because most of the routine diagnostic and monitoring functions have been transferred to the patient. And what you're talking about is downloading apps. We've been downloading a lot of apps over the last several years, since the smartphone came into being. in '07. And this is just an extension of that. Our lives were changed totally by smartphones in every other sector of our world, except for healthcare and medicine. And that's about to go through radical change. So the fact is that this is simple, and the doctor then gets much more involved with oversight of that data, as well as the treatment side. So it makes a much simpler life for doctors if they're willing to accept a less control world.
So is it primarily EKGs, glucose, and blood pressure that are the kind of data that you'll be providing your doctor? What else?
Well, I dropped the device here.
Yeah, well, you have an electronic tail, so you might want to
Well,
watch
anyway,
that.
yeah, you got that. Thanks, Corby.
I do.
So the number one reason to see a pediatrician is because your child may have an ear infection. So you can do most of the physical exam through a smartphone. This is just an attachment. And this is an idiot-proof now conversion of a smartphone to an otoscope. So then the parent pops this in the child's both ears. It makes a 10-fold magnified view of the eardrum. It's transmitted to the cloud, and you get a diagnosis of whether your child has an ear infection or not without ever seeing a pediatrician. And then the only reason you need to see a pediatrician is if you get the answer that there is an ear infection, which is highly accurate, this algorithm. And then you get the pediatrician contact just to get the antibiotic. You don't even have to go see a pediatrician.
So is this something that you envision in the future? Has this been FDA approved, this device? Is it something we can go out and buy?
This device now is approved for interacting with a pediatrician, a network of pediatricians, not all pediatricians, who are familiar with this device and its algorithm, yes.
But does it mean that we can have, essentially off-label use, that it's accessible to any parent, even if the parents' pediatricians aren't part of the network, and they can say,
That's where it's headed. I mean, they just published a paper validating the algorithm, and that it was more accurate than pediatricians' diagnosis of ear infection, which was kind of striking. And a lot of these things are similar, like skin lesions and rashes being more accurate by app, computer diagnosis than by general physician diagnosis. So there are a lot of things happening right now to change the way routine diagnostics are made. And this is, I think, a really good thing. It's all part of the story about patients getting emancipated from this system that we've had today.
well, this sounds dangerously libertarian to me. But how...
Somehow I knew you'd say that.
But how, it sounds like a good thing to you, but think of other doctors. Isn't it enormously threatening to the entire structure of the doctor-patient relationship? How can it work into the traditional doctor-patient relationship?
Well, first of all, it's inevitable, right? This is inevitable change. This is just, what the fact is that we have this thing called Moore's Law coming to medicine, and that we have cheap chips, and that we have over 2 billion transistors in our current smartphones, and we have so much technological capability, and that is a way. And we have, by the way, in this country, we have $3 trillion of healthcare expenditures, and we have a way to make this a whole lot less expensive. So we have an economic crisis that's going on right now, which is another reason why this has got to go, because this is as good a solution to our economic crisis beyond the fact that by the way, Corby, if you don't want to do this stuff, you don't want to take, that's okay. A lot of people will be happy with being in the paternalistic world where doctors rule the roost and know best. You can just sit tight.
Passive, ignorant sheep.
There you go. You can live like that. It's okay. But for the 80% of people.
That's part of the libertarian creed.
Yeah, so this is a choice. Every survey suggests that over 80% of people in the U.S. want their data, and they want to take much more charge. So it isn't for everyone, and there are a lot of super seniors that are very happy with the way things work today. But
Did you say super senior?
Yeah.
And how did you mean that?
Well, over 90, they're not going to change. They're not exactly going to have all this data flowing to their smartphones. A lot of them still don't even have a cell phone or a flip phone or whatever they have. So as you get younger and younger, and the digital natives, this is the way they expect. And digital doctors that are coming out of med school, they get it. That's what this is going to be like. So some of your questioning is about that this is such a radical change in the doctor-patient relationship. It's so fundamentally different. And it's partly because you've been suppressed so long. You lived in a paternalistic world so long that you're not ready to rise above it.
Yeah. Loosen these chains, Dr. Topol.
Yeah, we've all been treated as patients as the Rodney Dangerfields. That's what we are, and it's time to get out of that mode.
But what are some of the other diagnostic tools that are available? I mean, when you say this, what I'm thinking to myself is doctors for years now have been confronted with patients who do an enormous amount of research on the internet and come in armed with a whole series of questions, if not suggestions. And that is, I'm plugging a piece in the Atlantic because Eric completely, without my personal request, tweeted a piece that I, as editor, had been working on for quite a while by Jenny Rothenberg-Gritz about integrative medicine, a review of the kind of recent history of integrative medicine, which there's a whole other center at UCSD, right down the road from you.
Oh, and at Scripps too. Yeah.
And at Scripps. But the idea that patients are taking more control of their health care and they're researching a whole wider range of treatments and therapies than they once did. But even if this has been part of practice, doctors haven't been particularly wild about it, has been my impression.
Well, let's put it in perspective. Doctors are not wild about losing control. Mm-hmm. They diss patient-generated data. Oh, if you generated the data, then it's by definition worthless or close to that. Mm-hmm. So we have to change to a different mode, which is giving respect for data that's been rigorously reviewed by regulatory agencies, that it's highly actionable, and that there's this thing called computers and software that's going to take more and more. One of the greatest reflections of why this world is changing quickly is we now have the tech titans into healthcare and medicine like never before. Mm-hmm. We've got Google, Apple, Microsoft, Intel, Qualcomm, Salesforce, Facebook, all coming into medicine, and IBM, in a very large way. That has never happened before. There's been passing looks by Google and Microsoft years ago, but this time they're in it for the long haul and seriously committed to resources. And so when tech titans come into this space and where technology is today, this is something that is destined to move forward. And there's big public support. So I'm not concerned that this is not going to take hold in spite of the doctor resistance. Now, what you're getting at is this change will not occur from within the medical community. Mm-hmm. There is tremendous resistance. Mm-hmm. It has to come from outside. And the two biggest likely ways that it can occur, one is that large employers, the ones that have hundreds of thousands of employees and are paying several $1 billion a year for healthcare, mm-hmm. they could say tomorrow, by the way, I'm not having my patients go, our family, our employees, they're not going to have the old way of medicine. They're going to get all these things, and they're going to have a lot less expensive and a lot more effective form of medicine. And once that happens, then a whole bunch of other companies will follow suit. All it takes is just one to get this cascade started. And then the other thing that could happen is a consumer uprising, activism. That will probably take longer, but it probably will go part and parcel with the employer revolt, which is fomenting right now, because a lot of big companies can't survive with the cost of healthcare today. Mm-hmm.
That's certainly true about economics, and I'm going to ask you in a minute about something very striking you said to me, but I've wanted to ask about something that struck me during this conversation, which is the number of devices and practices you've said are regulated. So does that include diagnostic software or only devices, like the EKG and the otoscope and the blood pressure watch? I thought FDA just did devices. They can't get involved in programs or apps.
No, they actually put a lot into the review of the software, the apps themselves.
One's connected to devices or even independent of devices?
Both. I mean, I think that there's pure software reviews as well as the combined. Most of these, of course, have an ad or hardware as well as software, but they're thoroughly reviewed as a system. Do they work? Are they accurate and valid?
Would that not be reassuring to doctors?
It should be, but remember, even with that reassurance, there's a lot of circumspect that these technologies are assuming a partially, role of doctors. And it's a big challenge. It's a big challenge to the business of medicine, which you alluded to, but it's also, I think, even more of a threat of the autonomy of doctors, which has been around for more than 2 millennia.
Would you not tell doctors, and do you, I don't know how often you address groups of doctors, that this is actually a relief of your burden and this is helping save you time?
I've said that to large groups of doctors. I'm not sure that they buy into that yet, but I think over time there will be increasing acceptance of that phenomenon.
And the arresting figure you said was in the $3 trillion medical marketplace. You think that 1/3 of that is waste. And how did you mean waste?
Well, what we're talking about is that there's so many forms of not looking at each person as an individual. So for example, we still do mammograms and PSA tests in this country. Mammograms have a 60+% false positive rate. They lead to all sorts of bad things, biopsies, surgeries, radiation, chemotherapy, unnecessarily in the majority of women. PSA is the same thing. So that's $14 billion a year from mammography, which should be abandoned as a routine screening by all the data, but we have this emotional entrenchment about things. Same for PSA. It was abandoned as a routine screening, but it's still being done all the time. So that's screening, and all routine screening fits into this waste category. It's not individualized. Then we have the drugs that I mentioned, the top drugs, 80% of which don't even match up to the patient or engender serious side effects. The 4th leading cause of death after heart disease, cancer, and stroke is?
Falls.
It's medication errors and adverse events. The toll on that is profound. And so we don't match up medications, the right dose, the right medicine to the right patient. And basically, everything we do is not individualized. But we can get there because we have the ability now to construct a Google medical map for each individual. Everything from their physiology through sensors, the anatomy through scans, their external features, their phenome, and then their DNA sequence, the relevant parts of it. Like, for example, you can have a saliva test for a couple $100 for all your familial cancer genes sequenced. And all the other proteins, the metabolites, the microbiome, which is of increasing importance. And even you can use sensors for your environment, to quantify your environment. So we have a new capability in medicine we never had before to have this high definition human being and to get out of this waste, this ridiculous way that we've practiced medicine all these years, which is mass medicine, population level.
That's a very sweeping statement. And do we have any doctors who wish to rise up and ask Dr. Topol questions? Actually, I wouldn't invite combative doctors, but I do invite questions from the audience. And I will ask that you state them in the form of a question, a specific question Dr. Topol could address. Thanks.
Hi, my name's Holly. I'm not a doctor, but I'm a nurse.
Okay.
And I totally believe in what you're saying. What can I buy today of those apps you're talking about?
Well, the ones that are available, of course, you get skin apps to interpret a skin lesion or rash. There's several.
But how? Do they measure something? Is there something that you stick in that provides it? Is it a cell phone picture?
Cell phone picture. The cell phone pictures are high resolution, and they're great for computer algorithms. Perfect, in fact. And they've been validated. So you want to get a good, there's some that are not good and some that are, like University of Michigan has a great free app. And so
and I will ask, is there some kind of rating service you recommend? Is there some general CNET-like product, whichever you choose?
I tried to review everything in The Patient Will See You Now up to that. That just came out in January. It was pretty up to date. So there are new things coming. But we do need a rating. We need a Consumer Reports.
Right.
We need that for this field.
Business opportunity, everybody.
Yeah. So the electrocardiogram is available. You can order it through Amazon. There's 2 different ones and FDA approved. The glucose is available as a continuous sensor, but it's still expensive, so you might want to wait till it gets much cheaper.
What does expensive mean?
Oh, well, the sensor that is used. There's two in the U.S. There's a third one also available outside the U.S. Dexcom, Medtronic, and Abbott. And we're talking about for a year of sensing glucose continuously, a couple $1,000s. Often paid by insurance if you're a diabetic and you have insurance, but still, it's going to be the cost of this is going to plummet because we have much better sensors coming that are very inexpensive. And that's highly regulated by the FDA, by the way, the software and the sensors. What else is available now?
The otoscope?
The otoscope is a good example. A lot of the physical exam, there are tools that are available. This thing is actually, I neglected to show, but this kind of is a good icon for the future of medicine. So you know sleep studies. It's one of the most highest revenue centers in health systems. You go to the sleep medical lab, and I don't know how many of you have had this, but I don't know how anyone could sleep normally in a hospital sleep lab. And I've yet to have a patient who's had one of these tests who had a normal result. And it costs $3,500 reimbursed by Medicare. Some charges are up to $10,000. This costs $1 to make. You put it on your chest, and it gets your oxygen concentration continuously, your respiratory rate, your heart rate, and it basically does all the things except that you're at your home in your own bed. And it does it for a week rather than one night, a Band-Aid. So that's just to give you an example. It's not yet approved, but it's going through FDA approval right now.
Of course, that was all of our next question. And is it in fact only for the, all night long, or does it work all day long? And is that something that could?
You could wear it all day long, but if you're looking for sleep apnea, which is a common problem,
of course, very.
And it needs treatment, you just really want to have it on at night.
There was a hand up in the middle of the room, that woman, and then I think a gentleman in the front.
Thank you. I'm Kathy Kemper. I'm an integrative pediatrician, and I really appreciate what you're saying. I wonder if you can talk about therapeutic delivery. You talked about getting all this information diagnostically, but the patch really caught my attention. As a pediatrician, we give a lot of immunizations, and babies hate it, and parents hate it, because it hurts.
Yes.
And so do you see the advent of patch delivery of multiple immunizations at once, and can you speculate on other advances in therapeutic delivery?
Absolutely. No, that's a biggie. The microneedles that you don't even feel that can administer a vaccine or on the other hand, take out a droplet or a few droplets of blood are now being pursued through FDA to get approval, to be a whole new way to immunize. And it'll be a great thing for kids. And infants. So that should be not so distant future. Pretty darn impressive technology. It's amazing it took this long to get rid of the pain factor with immunization and also, of course, with finger sticks and all that kind of stuff.
Great. The gentleman there, and then the gentleman in the yellow sweater.
I suspect there are going to be a lot of use for this stuff which will bypass doctors and be people to people. For instance, I'd be very curious about how my airplane pilot is feeling during the day and whether he has any schizophrenia. Well, we saw an airplane pilot fly his plane into a mountain a couple of months ago. It was a startling event. And there clearly would have been chemical markers in his blood that would have suggested that he might not be in that airplane.
Yes.
I can imagine that my granddaughter might well like to have the disease history of a young man she just run into before she goes out with it.
You got it.
There are a lot of applications.
I think you'd very much like that for her.
Yes, sir.
So he was going to ask that. Thanks.
Great point. So firstly, when that happened with the pilot deliberately taking down the plane, it also brought to question is we can quantify mood state and depression now. We've never been able to do that before. So with things like a wristband to get autonomic nervous system tracking, galvanic skin response, heart rate variability, vital signs like blood pressure, the facial recognition, which is really powerful now, all sorts of software to process that, and that includes breathing pattern, but most importantly, voice. Tone of voice and inflection of voice is a powerful way to quantify one's mood. And then if you really want to get fancy, you can add brainwaves, there's a lot of brainwave. I didn't bring it, but you can, just a headband that gets brainwaves. So you can quantify, and this is the number one cause of disability, depression. So that is going to be a whole new look, because so many people can potentially avoid medicines or get better titration for medicines. And then what you're bringing up is, could we then use this as a tool for knowing when people get in trouble, when they have, for example, they're really getting down. They're getting more towards a potential suicide and that sort of thing. Or
if
hurting
I
other
may, and
people.
I'm going to move on to another question. That's a great question. It brings up a whole world of ownership of data.
Yeah.
You're so intent on owning one's own data. That's one thing. But the question implies, what about all the passengers in the plane? What about your worrying grandparents? What about your employer, for example? And what do you see as the boundaries of ownership?
Yeah, well, that's actually my biggest concern of everything we talked about is privacy and security. And it has to be kept to you or your family members, whatever, your children. And we don't have any safeguards for that right now. We have two wonderful white papers from the White House with absolutely zero action to follow up on that. There's technological solutions to secure the data for the individual. There also has to be legislation, which you touched on, that we don't have this protection. So that needs to be enacted, and we're way behind in that. So we have data capture, which is extraordinary, and we have pitiful analytics, essentially, and safeguarding privacy.
That's an enormous concern that I'm glad you brought up. The gentleman's been patient with the glasses. Thank you for that question.
Hey, so my question kind of follows up on that. So given, chain of custody of information, HIPAA, interoperability, and the type of doctor you're describing, when is this happening? Because you still have treatment in the hand of the doctor, so there is an exchange here. So when do you see that all coming together? So there's the when, and then I'm more curious about this. When it happens, what does the doctor's exam space look like?
Right. Well, the doctor's exam space that you're used to going to the doctor's office, that's going to be a rare occasion. That's going to be the minority of encounters in a doctor's office. Much more of these are going to be virtual, whether it's video or other means. The when, it's happening now, it's a very small segment of the medical community because of the factors that we've already discussed. But if patients demand it, it will happen more. This is just something that, if they're not, for example, 70% of US doctors will not give their patients their notes, the office notes. If you're one of those patients, you might say, it's time for me to get another doctor. Because they're not even willing to give the notes. They're not going to do any of this other stuff, believe me. So we have to see activism among consumers to look for doctors if they want to get this form of medicine, which is going to become increasingly available, and it's going to be particularly common among younger physicians.
Yeah, and I thought that it was already mandated. The lady with the yellow lanyard here, and I think that might have to be the last question, I apologize.
Breast cancer remains a major risk for women. So if you think mammograms are generally a waste, what would you suggest? That all women have genomic testing to start out with so you know if you have a high risk for cancer and then go from there with mammograms, or what?
Right. Well, firstly, there's a thing like family history, which is really important. And so that's one thing. And then now that we have this remarkably inexpensive sequencing of all the relevant genes for a couple $100, that if you could have every single woman in the United States with genomic testing, and it would be cheaper than doing annual mammography, which that's the kind of testing we need to do to decide whether or not this is the way to go forward. But the idea that every woman, but by the way, the U.S. Preventive Task Force has already abandoned women younger than age 50 or older than 74. So we're only talking about one group of age, and that group, the data are untenable for recommending routine, annual, or even biannual screening. So we need better ways, and you touched on them, genetic screening, which has now become, we're not talking about a genotype, we're talking about sequencing, the culprit common genes that are linked to breast cancer. So in the future, that's going to become the real deal.
You have brought up an enormous range of topics about the future. We would like to go on with this. I have a feeling that you're not going to get very far from that lobby for the next 45 minutes. But I'm delighted for the hour that you gave us this morning. Thanks very much.
Thanks for having me. Thank you.